Dear colleagues, welcome to the webinar, Health and Development, the Absence of Disease is Not Enough, part of our webinar series on building health throughout the life course. Good morning, good day, good afternoon. My name is Sonia Cafe, and I am the Regional Advisor on Adolescent Health at PAHO. It is my pleasure and honor to moderate this very interesting panel with a fascinating lineup of presenters. We have experienced panelists who will be sharing their knowledge and expertise in the area of life course and the importance of the first 20 years of life for health and development of children and adolescents to nurture the skills and capacities they need for later development. Before we start, I want to share with you some instructions. Today we have simultaneous translation to Spanish, Portuguese, and English. Fernando, can I ask you to share the instructions? I see they're already on our screen. So if you go to the bottom of your screen, you will find a global shaped icon. If you click there, you will see the three options. And if you click again in the language of your preference, you will have access to that specific language. So let me repeat, at the bottom of your screen, a little bit to the right, you will see the globe-shaped icon. You click on that, and then you have the option to select English, Spanish, or Portuguese. We won't have a Q&A session, but you can use the chat, and we really encourage you to use the chat to put in comments and questions, and we will try to answer your questions as we go through the webinar, because your questions, your opinions, your contributions are very important to us. Thank you, Fernando. You can now remove the slide from the screen. Today, we have a very interesting set of speakers, as I mentioned. I also look very much forward to listening to and hearing about their vast experience in the topic that we will highlight today. Let me take a few minutes to introduce the first few speakers to you. Our unit chief, Dr. Enrique Vega, will make some introductory remarks. Dr. Vega is the PAHO unit chief of the life course He's a medical doctor and a specialist in gerontology and geriatrics. In his remarks, Dr. Vega will highlight key aspects of the webinar in the context of the life course, and why it is so important to address the topics we are going to discuss today, including some key concepts and foundations of a life course perspective. Following Dr. Vega, we will have a presentation titled The Life Course Approach for Health and Development, Concepts and Foundations by Dr. Christopher Forrest. Dr. Forrest is a professor of pediatrics from the University of Pennsylvania School of Medicine. Dr. Forrest is a pediatrician and health services and outcomes researcher. He leads several multi-institutional collaborations that are advancing our knowledge on how to improve the health of children and their well-being. Currently, he is working with colleagues across the US to catalyze the new field of life course health sciences, LCHS, which is concerned with how an individual's dynamic interactions with their environment produces health over the lifespan. He co-edited the new handbook of life course health development. Following Dr. Christopher, Dr. Raul Mercer will be presenting on A Future for the World's Children, a WHO UNICEF Lancet commission in the context of the life course, Dr. Mercer is a doctor in medicine, epidemiologist, and a public health specialist. He is an international consultant in the area of child health, adolescent health, and women's health. Our third speaker in this first set of speakers is Dr. Wilson Ware from the World Health Organization. His presentation will be on redesigning child and adolescent health programs. Dr. Ware currently works as a medical officer, child health services at the Department of Maternal, Newborn, Child, and Adolescent Health at WHO in Geneva. Dr. Wilson is responsible for child health policy, guidance, and quality of care, and does research in policy, health systems, epidemiology, international health, and infectious diseases. This is wonderful. I cannot wait. Let me start by inviting Dr. Vega. Dr. Vega, the floor is yours.
Thank you very much, Sonia. Gracias. Muy buenos días.
Thank you very much and good morning. Good morning to all of you, and thank you very much for connecting to this webinar today. I believe that, as Sonia said, it's going to be a really very important webinar where we'll be able to learn a great deal about this topic of how to give a life course approach to our public health interventions. In the first place, I'd like to thank our unit for all their support, and particularly for the leadership of Dr. Andres de Francisco, our head of department, and for the very intensive work that Dr. Carolina Holmes and Dr. Sonia Café, Dr. Pablo Duran have all been developing at the beginning of this event. And thank you, of course, to our speakers who represent the planet's opinion practically. We have a lot to learn from them. They have been leaders in this topic for decades, and I believe that they bring us a fundamental summary so that we can learn how to apply and translate this knowledge into our daily practice in Latin America and the Caribbean. I had a chance to talk to most of the speakers together with Carolina and talk to them of what we wanted from this seminar. And of course, it was incredible learning that simple conversation. And I wanted to take advantage to summarize 5 ideas which I believe fundamental in this question of life course, and how this webinar can help us understand the life course and how to apply this in our daily public health practices. The first is that you take back with you the idea of seeing health as a capacity, as a resource, a valuable resource for human development, but also a capacity and resource which is not innate, which has to be built throughout the lifespan, and which requires a fundamental effort from the institutions as well as the individuals in that specific development. Second, that the first 20 years of life imply a maximum opportunity of cost effectiveness to develop the capacity, the skill, and to have a definite influence in the whole health and development trajectory of individuals and populations. The third is that actions and lack of actions or inaction during this life span will have an important effect in the health trajectory for life. We want to remind you that not to do anything doesn't have a zero cost, that the first 1,000 days of life are essential because of its possibility of developing the human being, but that's not enough. Investment in health and development must be intensive and decisive until the human being matures. And lastly, that to prevent disease is important, but not enough. That to promote health is important, but not enough. That we must build health and do it in a way that we develop the skills that are measurable and allow maximum development of human capital. Thank you very much. And I wish you all success. I hope you enjoy this webinar.
Thank you so much, Dr. Vega. I now invite Dr. Christopher Forrest to make his presentation.
Okay, can you see the screen?
Yes.
Great. Thank you so much to the conference planners for inviting me on behalf of my colleagues to present our work today on life course health science. I'm going to spend about 15 minutes with you to help you develop an understanding of what we mean by this emerging field of life course health science, as well as its transdisciplinary principles. I think one of the primary messages that I want to convey is that life course health science, that is the scientific inquiry into how health is produced from before conception to death, is more than just connecting the dots, more than just connecting the dots between fetal life, childhood, adulthood. Life course health science is about the systemic production of health and integrates developmental science into our notions of the life course. So let me take you through a now 14-minute journey on life course health science. And I hope if you want to explore more, that you will check out our Handbook of Life Course Health Development. This was published in 2018. The second chapter is the substrate on which I will base the discussion today. It is written by myself and Dr. Neil Halfon, but the book fleshes out the principles of life course health development, and it's fully accessible. All you have to do is Google it, and you can download any of the chapters that go into different stages of life, different diseases, as well as the chapters that I wrote on the theoretical principles. So let's begin with historical analysis, a high-level overview on how science has treated health in terms of its production, understanding how health is produced and how we may then intervene in order to optimize human health across the lifespan. Several early models drove, around the turn of the century, drove our thinking about health and actually led to enormous advances in our understanding on how health is produced and how health can be improved. The notion that there are genes that can lead to ill health was a revolution in our understanding of the molecular origins of health. However, today we know there are very few diseases that are caused by single genes. And in fact, the analysis of the human genome has led to important advances, but hasn't really revolutionized our ability to treat health across populations. Perhaps more important was germ theory and understanding how microbes, viruses, bacteria, and fungi can cause ill health, leading to ultimately antimicrobial therapies, as well as immunizations. And then the ability to look into the depths of the body through microscopy and understanding that there are pathological lesions in specific tissues, the so-called anatomical pathological framework, helped us understand how we might excise certain kinds of disease tissues and improve health. All of these, plus a few other models, you could summarize as the biomedical model, which has been the dominant model in healthcare over the last 150 years. The biomedical model is the model that you want if you, say, break your arm and you go to see a healthcare provider. You want there to be rapid analysis of what happened, and then a rapid treatment of your broken bone. The model, however, in terms of its ability to explain health, has a lot of limitations. It is reductionistic. It does bring down to the smallest possible analyzable unit some aspect of health or its determinants. Advances in the latter part of the 20th century, however, began to call into question this anatomical, pathological, analytical reductionist model as the dominant model. In the United States, large epidemiologic studies, such as the Framingham studies, the Alameda studies, led to the notion that there were social factors, not just biomedical or biologic factors, that caused ill health, social isolation, or friendships on the positive side. In addition, the behavioral sciences began to teach us that there were various kinds of activities that we could engage in to promote health through, say, physical activity, or to lead to ill health, say, through excessive caloric intake. These studies led to the idea that there were social and behavioral determinants that, in combination with some of the more biologic factors, can produce health. And that model was sort of coined in terms of its moniker by George Engel when he wrote in Science magazine about the biopsychosocial model. The biopsychosocial model recognizes that people live within multiple contexts, that the influences of family and community and the biosphere, this hierarchical nature of our environments, were very important in determining health. Analytically, it led to the notion of hierarchical models, looking at how area level factors influence individual health and how individual factors may influence area level factors. And you might say that the model was complex. It took a lot of new variables and tried to isolate the independent effects of multiple variables. But even the biopsychosocial model, as we've turned into the 21st century, has been challenged. We now recognize that there is an important aspect of development that can lead to changes in the brain. We now know that childhood adversity and various types of parenting practices can lead to specific alterations in young children's brain development. We've learned from studies in the United Kingdom, New Zealand, and other countries that what happens in fetal life, say through intrauterine growth retardation, can have long-term effects in adulthood, this notion of life course epidemiology. We've begun to find epigenetic signatures of environments, particularly adverse environments, on the immune system, the endocrine system, our ability to respond to stress. And we see how development over time is beginning to produce health. So the combination of these new scientific findings, plus the biomedical model and the biopsychosocial model, has led to the synthesis of what we call life course health development, or the science thereof, life course health science. Life course health science recognizes that health production is complicated. People live within systems. They are networked with each other. Their lives are linked with each other. They are in constant and dynamic interaction with their environment. So the models that we need to use analytically are very different. It's interrogating systems, and the improvement structures that we need to put into place through policies, programs, and practices need to take a systems perspective. So life course health science synthesizes across biomedicine, lifespan psychology, both biological and psychological developmental systems theory, complexity, etc., a variety of fields being brought together in order to better understand how to understand health and ultimately improve it. Let's take this framework now and apply it to the developing child. A child lives in what we will call a dynamic relational environment. They are in constant interaction with their family and their community, their physical environment, and the policies that structure the environments in which they live. These interactions are continuous, and what happens today depends on what happened in their prior life, as well as in their parents' life. There's a connection across the generations in understanding the health production. So this child is no longer can be thought of as isolated from their environments. They need to be considered within the context of their environments. And that's a very different way of thinking about health production. These constant and dynamic interactions have a various types of time dependency. There are time specific and time dependent cumulative effects that can lead to changes in the emergent phenomenon that we'll call health. So health in the model of life course health development isn't the absence of disease. It's actually the things that we need in order to lead the lives we want to lead. It's the biopsychosocial functioning that's necessary to construct life projects that we find worthy of our time. It's the ability to adapt, whether it's the immune system adapting to a infectious challenge, or it's our physiologic system adapting to stress, or it's our social environment adapting to a natural catastrophe. It's our ability to function and adapt, as well as the experiences thereof. So we have biological imprinting, which you can think of as experiences that result from environmental cues. And we also have the subjective experience of living our lives. The primary metaphor of thinking about health development is the trajectory. So life course health development requires that we think about health over time. It fuses health, which is the things that develop, it's the functionings, it's the adaptations and the experiences, with the mechanisms by which they change development. So health development subsumes, say, physical development, cognitive development, socio-emotional development. And there are both protective factors, such as a supportive domestic relationship for the pregnant woman, as well as risk factors such as poor nutrition that unfold over the life course. Different factors may be more or less important at different phases of life. And so you need to think about this balance of risk and protective factors, both today as well as in the past, in designing policies and programs. Fundamentally, the model is all about how to promote health capabilities, as well as health experiences, so that in combination with the opportunities that are presented to individuals and populations, as well as their independent ability to choose, their agency, they can construct their life plans and life projects. So on the left side, we're seeing that people are in dynamic interaction with their environments over time. That leads to the emergent phenomenon of health capabilities and experiences. But what's really important is generating in the developing child, the adolescent, and the young adult, the ability to be an independent agent and to be exposed to a world in which they have opportunities to flourish, to lead the lives that they want to lead. This is a slide that shows that across the life course, different contexts are more or less important. So for the young child, the family is of primary importance. But as kids move into school context, community context, peer relationships become more important. In our handbook, Mummert and colleagues wrote about human growth, growth in terms of height and weight, that it is a record of individual health experiences. So see here, there's this time dependency, and that growth unfolds as a complex adaptive system. So here, another principle, complexity. That growth is not deterministic, that growth actually results from dynamic interactions between people and their environment. And then our growth is sensitive to the changing circumstances of our environment. Thus, the human body unfolds, that's another life course health development principle, as a result of its growth and maturation. Back to the trajectory metaphor, bear in mind as you start to think about trajectories that at any point in time, the trajectory is determined by the multiple dynamic relationships of environmental context, as well as what happened in the past. A very, very important principle in life course health development is timing. There are time-specific effects where certain environmental cues may condition or actually alter through adaptive plastic responses, biological and behavioral systems. And the same exposures can lead to different outcomes if they occur at different parts of the lifespan. There are many now studies that show there are time-specific and time-dependent pathways that lead to negative outcomes. And the outcomes vary by the stage of the life course. So these are all outcomes on this slide that emerge later in life that are related to adverse conditions during childhood. To summarize the book and my talk, I provide this slide. Health and development are unified into a single construct, the health development principle. So in other words, health, development, fused. They're not separate. We don't talk about developmental outcomes or health outcomes. We talk about health development outcomes. This notion of health development capabilities and experiences adaptively unfold over the life course. So that's the unfolding principle, according to the principles of complex adaptive systems. So think about health not in the context of social, behavioral, and biologic determinants, but of the production of health through systems, through interacting systems. It's a very different way of thinking. The change in health results from time-based processes, the timing principles, both time-specific, i.e. exposures that may occur at specific points in life, as well as time-dependent, i.e. cumulative effects over the life course. These time-specific, time-dependent pathways can influence health through their interaction with developing biobehavioral systems. When the developing child is most susceptible to change, the so-called plasticity principle. Health development, therefore, provides a set of assets that enable individuals and populations to pursue their desired life projects. And when they are pursuing those projects in ways that they find fulfilling themselves, defined by their own personal preferences, by their culture, by their family, by their history, they're thriving. Thanks for the opportunity to share our work, and I'm looking forward to the rest of the talks.
Thank you so much for this very interesting presentation. Dr. Forrester walked us through some key concepts related to the systematic production of health and the complex set of factors that influence this process. People have been asking, we can confirm that yes, we will be sharing the tape and the presentations so you can go through them again at your leisure. The next two presentations will focus on how the life course approach is translated into public health practice. And so I now invite the first of those two presenters, Dr. Raul Mercer, to make his presentation.
Thanks, Sonia. My presentation will be in Spanish. So I will start with the one issue that it came after listening to the excellent presentation of Christopher. Cuando Christopher se refirió al tema de la salud relacionada con la posibilidad de construir planes, proyectos, oportunidades, es una pregunta que yo generalmente hago cuando trabajo con profesionales y les pregunto ¿cómo han construido su trayectoria de vida? ¿Están conformes? ¿Han tenido algún problema a lo largo de sus vidas para llegar a ser lo que son? Y bueno, cada uno responde en cuanto a haber tenido alguna traba en su vida o algo que truncó un proyecto. Y en ese grupo son personas que son elegidas, son personas que han accedido a una formación, a una educación, pero una proporción importante de la población en América Latina no tiene esta posibilidad de construir de manera libre e informada sus proyectos de vida. Dicho en otras palabras, no acceden a opciones para decidir libremente sobre su salud y sobre sus cuerpos. Y esto se traduce en complicaciones, en enfermedad y en muerte. Los aspectos que vamos a abordar en la
The
presentación tienen que ver
things we're
con la
going to deal with
salud
in my
y los cambios de
presentation have to do with
paradigma
health and changes
y
in
ahí el
paradigms,
enfoque de curso de
and
vida.
hence the life course
Una
approach.
breve descripción de la
A brief description
trayectoria
of
histórica
the
en cuanto al
historical
acceso a este
trajectory
enfoque,
of the
algunos
access to this
argumentos que
approach.
conversamos
Some
con
arguments we
Carolina y
talked
con
about with
Enrique en
Carolina
cuanto a la
and Enrique
importancia de
regarding the
incorporar
importance of
este enfoque
adding
en el campo de
this
salud
approach in
pública
the public
y
health
aprovechar
field,
este
and
momento
to
para
take
agradecerles
advantage
la
of this moment to
invitación.
thank you for this
Una
invitation.
breve
A very
reseña sobre
brief
el informe
description
Lancet,
of the
OMS y
Lancet
UNICEF y
WHO
finalmente
UNICEF report,
visualizar
and
el
finally
campo
to
del enfoque de curso de
visualize the
vida
field of the
como
life course
un campo
approach
de
as
integración
a
desde la
field of
salud pública.
integration from the point of view of
Simplemente
public
a modo
health.
recordatorio,
Just as a
se
reminder,
acordaron
simply
ustedes de la
you
definición
recall
de la OMS
the
de la salud
definition of the WHO of health
basada en la
based on
caracterización de un
the
estado
classification of a state.
y investigando algunas de
And
las
we
diferencias que están
investigated some
en
of
la
the differences
literatura,
in
el Sistema
literature.
Nacional de
The
Salud de
National
Inglaterra
Health
define a
System
la
in
salud
England
como una
defines health as an
experiencia, como
experience,
un continuo,
as a
o sea
continuum,
que es una visión
since it is a
totalmente
completely
antagónica o diferente,
antagonic or
digamos,
different
a lo que fue la
view of what
definición de OMS que
the
se hizo en el
definition of the
milenio
WHO
pasado.
was in the past
De esta
millennium.
manera estamos haciendo un
Hence, we
tránsito
are
conceptual
creating
para
a
ir desde una visión
conceptual
en
change,
snapshot,
a
una visión
vision, a
fotográfica
snapshot
de la salud,
of
a
health,
entender la salud
and
como
going
un
to
proceso,
understand it
como un
as a process,
constructo,
as a construct,
como algo que
as
vamos de
something
alguna
that
manera
we
construyendo en el día a
somehow
día a lo
build
largo de
day in
nuestros
and day
trayectos
out throughout
vitales.
our lifespan.
Por otra parte,
On the other hand,
sabemos que existen
we know
muchas
that there
lentes para
are
entender la
many
salud.
lenses to
Y
understand
estas
health,
lentes
which
son productos de la
are the
existencia de
result of the
diferentes
existence of
paradigmas
different
que no son
paradigms,
ni más ni menos que
which are
modos de
nothing more
explicar a la
than
salud.
a way to explain health.
Tres comentarios.
Three
El
comments.
primero
The first
es
is
reconocer
to
que estos
recognize
paradigmas o estos enfoques
that these
existen en
paradigms
la
or approaches
realidad
exist
y que esta
in
lista que
real
aparece en
life,
el
and that the
slide
list that you
se
see
va
on this slide
incrementando con el correr del
is
tiempo en la
increased in
medida que
time
avanza el
as
conocimiento.
our knowledge advances.
El segundo
The
elemento es
second
que
element is
los enfoques
that
o estos
the
paradigmas no
approaches
son
or
mutuamente
paradigms are
excluyentes. No
not
es
mutually
una
exclusive.
cuestión de generar
It's
una
not a
situación de
question of creating
enfrentamiento de
a
un modelo
situation
contra
where we
otro.
confront one model with another.
Lo grave
What's
podría
serious here
establecerse
is
cuando queremos explicar la
when we
salud,
try
que
to
es algo
explain health,
complejo, desde
which
una
is
sola
something
lente.
complex, from a single
El
lens.
tercer
And the
comentario
third
es
comment
que estos
is that
paradigmas o estos
these
enfoques
paradigms or these
están
approaches
relacionados entre
are
sí.
related to each other.
En nuestro caso, tomaremos
In
el
our case,
enfoque
we
del
are
curso de
going to
vida, que es
look
el
at
eje que nos convoca en el día de hoy.
the life course approach,
Un
which is
elemento a
the
destacar
element
es que el enfoque
that
de curso de vida
is central to
nos
this meeting.
permite
The life
detectar,
course approach
yo
allows us
diría,
to
la mayor
detect
amenaza sobre la
the
salud
highest
mundial,
threat
que no es
for
la pandemia.
human
Yo diría que la
health
pandemia más
that
grave
is
se
not the
llama
pandemic.
inequidad,
I would say
exclusión
that the
social como
greatest
expresión de
pandemic is
injusticia.
social
Y estas
exclusion and
inequidades acontecen
inequalities.
tempranamente
And
en
out
la
of
vida
these
en la
inequalities,
región del mundo en
we
donde las
see
inequidades son
impact
es la
throughout the
región con las
world in
inequidades
various
más
areas of the
manifiestas.
world where
O
we
sea
see
que la buena
the
noticia es que si
clearest
tomamos en
inequalities.
consideración
So the
estas
good piece of
inequidades
news is that if we
que
take into account the
acontecen desde el arranque de la
inequalities
vida,
that we
podemos
see
actuar
at
e
the
intervenir
outset of life,
tempranamente para que
we
esto no se
can
vaya
act
incrementando
quickly
con el
so that
correr del
this does
tiempo y lo que
not
es más grave, que
intensify
se
as time
reproduzca
goes
de manera
by and
intergeneracional,
we
como es el
prevent
fenómeno de
its
reproducción
reproduction
intergeneracional de la pobreza.
throughout
El otro
different
elemento a
generations as what
destacar
we
tiene
see
que ver
with
con los
poverty.
derechos.
And
Cuando
the other
hablamos de
important
derechos, hablamos de
element to mention
dignidad
has to do
y
with
hablamos
rights.
de
When we talk
derechos
about rights, we
que
talk
son
about
necesarios
dignity
justamente
and
para
rights that are
satisfacer los
necessary
aspectos de una vida
to comply
saludable
with the
y
aspects
de
of a
alguna
healthy
manera
life
basada en la autonomía de las
based
personas para
on
decidir
the
libremente.
freedom of
Todos sabemos que los
individuals
derechos son
to choose.
interdependientes, son
We know that
indivisibles
rights are
y son universales.
interdependent, are
Y cuando hablamos de
indivisible, and
estos
they are
aspectos de
universal.
derechos,
And
nos
when we are
referimos
referring to
a
these
los derechos que
aspects of the right,
atraviesan
we are
cada uno de
referring
los
to the
grupos de edad.
aspects that
Las
go
mujeres tienen sus
across
derechos,
different
la población infantil y
ages.
adolescente tiene
Women
sus
have
derechos,
their own
la
rights as
población
well as
adulta
the
tiene sus
youth.
derechos vinculados
The
con el
adult
mundo del trabajo
population
y las personas que
also
están en
has
proceso de
their
envejecimiento
rights in
también
connection
tienen sus
with
derechos
work,
con sus
and also
respectivas convenciones que
the
garantizan los derechos,
elderly have their rights
atendiendo a los
through
aspectos
various
particulares de cada
conventions
grupo etario.
that have to do with
También las
specific
personas con
needs of each of
discapacidad
these
tienen sus
age groups.
derechos,
Individuals with
pero debemos
disabilities
reconocer
also
también
have
que a
rights,
diferencia
but
de
we
las
need to
capacidades y las
recognize that
funcionalidades
contrary to
que
the
van cambiando a lo
rights
largo de la
and
vida,
roles
derechos
that
se
change
mantienen
throughout
con la
time.
misma significación
Rights
y la misma
are
importancia
maintained
a
with
lo
the
largo de
same
todo el curso
importance
vital. O
throughout
sea que un
the
recién
life
nacido tiene los mismos derechos que una
course.
persona
So
adulta
a
o una
newborn has
persona
the same
adulta
rights
mayor.
as an
Lo que
adult
estamos proponiendo
or
acá es,
as
además de una
an
lectura
elder.
transversal de los
So we're
derechos,
asking now
proponer
that
un
in
enfoque
addition to
longitudinal, o sea,
reading
un
this
enfoque de curso de vida de
across
los
the groups,
derechos,
to also think
atendiendo a
of
que la
the
promoción de
course
los
of
derechos
life,
en una etapa de
their
la vida
rights, and also
tiene un
bearing
efecto
in mind
beneficioso
that
en la etapa
rights also
subsiguiente.
have an
Vulnerar
important
o violar los
impact
derechos
in
en una
later
etapa tiene
stages. To
consecuencias negativas
breach
a lo
those
largo
rights,
de
to
la vida de las
violate those
personas.
rights also has an impact on the
Ahora
life of the
hagamos un
people.
breve recorrido en
Now
cuanto a la
let us
trayectoria, cómo uno
briefly
llega
look at the
al enfoque de
trajectory,
los
how we
derechos.
get to the
Hace
approach on
aproximadamente 30
rights.
años,
About
algunos
30
de ustedes
years
no habían
ago,
nacido,
some of you were not even born,
escribimos un libro para
we
lo que se
wrote
ha llamado
a
Manual del
book
Crecimiento y
that
Desarrollo
is
del Niño
called
para la serie de
Manual
partes.
on
Y en ese
Growth and
momento
Development of Children. And at that
tomamos
point
los
in time,
distintos aspectos
we
de la
took into
salud
account
como
the
una
various aspects
construcción,
of health
pero con un
as a
periodo de tiempo, un
construct,
eje
but also
temporal
as a
restringido al
temporal
periodo
axis that is
prenatal y los
restricted
primeros 6
to
años
the
de vida postnatal.
prenatal
Pero si
and the
ustedes
first
ven
6
en el
years of
slide,
life.
verán cómo los
But if you
distintos
look at
aspectos
the
vinculados con la
various
salud,
slides,
la
you're going to see how
prevención
the
o
various
distintas
elements related to
problemáticas
health
asociadas con el
prevention or
crecimiento y
different
desarrollo e incluso
problems
las
related to
inequidades
health and
fueron
development,
incorporadas en
including
ese momento
inequalities,
un
were
elemento que
included
ampliaba el marco de
as an
análisis
element to
y que se
enhance
contraponía
this
al fenómeno
analysis,
del
and that was
snapshot o la
contrary to
visión
the
fotográfica de la salud.
snapshot view
Por otra parte, más
connection with health.
adelante, tuvimos
Later
la
on,
posibilidad de ver
we had
cómo
the
el enfoque de
possibility
salud
to
en todas
see
las
how this
políticas
health
también podría ser
approach throughout
abordado
the
de una
policies
lógica
could
del enfoque
also
de curso de vida,
help us
y en
look
este
at
caso,
life
la
course.
propuesta
And
que
at this
trabajamos con
point in
Claire
time, the
Hertzman, quien
proposal that we
lamentablemente ya
work
no
with
está más,
Clay
con la
Hertzman,
doctora
who
Elia
unfortunately
Molina,
died, or
con
Elia
Ziva
Molina,
Bagri, fue
Silvia
ver cómo
Magri, was
reconocer
to
el
see how we
fenómeno
can
de inequidades
recognize
en etapas tempranas de la vida
inequalities
y cómo
in early
atacarlas
stages of
tempranamente
life,
desde
and
una
also how to
perspectiva de
attack
curso
them
de vida.
early from the point of view of the life course.
Más recientemente,
More
en un
recently,
trabajo que hicimos con la Universidad de
as
Santiago de
part of work
Chile,
that we
integramos
conducted
también
with
los
the
aspectos de enfoque de
University
curso de
of Chile,
vida,
we
la
also focused on
epigenética y los derechos humanos como
life
campos de
course
análisis
and
que nos
also
permite de
the
alguna
various
manera
fields that would
movilizarnos
allow us to
intelectualmente y epistémicamente a lo
intellectually
largo de las distintas formas de entender la salud que, como dijo
try to
Christopher,
understand the various
no puede
stages of
ser
life,
soslayada o
which
apoyada en
cannot
una visión
be
reduccionista
only
o en una sola
supported
lente.
on a reductionist
Y más
approach.
recientemente,
And more recently,
tenemos esta nueva
we
iniciativa
have this
denominada
new
Children in All
initiative
Policies, niños y
called
niñas en todas las
Children
políticas,
in All
que no es ni
Policies,
ni más
that
ni menos que la
is
forma de
the way
garantizar
to
o
guarantee
asegurar que las
or
recomendaciones del
that
informe
the
Lancet, al cual nos vamos
recommendations
a
by
referir en
Lancet
unos minutos,
that we
puedan
will be
ser
referring
seguidas
to
por los
briefly
países a escala
could
global.
be followed up
Y
with the
ahora
questions,
veamos
with the
algunos
countries.
pocos
Now
argumentos,
let
que es
us
lo que
look
me pidió
some few
Enrique,
arguments, and that is what
sobre
I
por qué es
was asked to
importante
do,
incorporar
as
el
to
enfoque
why
de
it
curso
is
de vida en
important
salud
to
pública.
include the life course
Primero,
approach in
hay
public
una
health.
justificación
First of all,
conceptual,
there is a
movernos de la
conceptual
visión snapshot a la visión del continuum de
justification
la
to move
salud,
from the snapshot to
del
the
abordaje de la
continuum of
salud,
health,
entendiendo que hay
to
múltiples
address health,
enfoques que se
understanding that there
relacionan
are
entre sí,
various approaches that are
de las lógicas
interrelated,
institucionales,
and
programáticas, sectoriales
the
y
program
políticas,
sectorial institutional
atendiendo que nuestras
approaches
organizaciones de salud están basadas
need
en
to
la zona de confort
focus
de los
on health
ministerios que poco tienen que
that
ver con la realidad de
sometimes
las
is within the
personas,
comfort
ya que las
area of the
personas no vienen
ministries,
fragmentadas en
distant from
capítulos o en
people, because
patologías. El
people are
problema
not
es nuestro,
fragmented into
como
chapters or
instituciones, en
pathologies.
tratar de responder a las
As
demandas de los
institutions, we need
individuos
to address
y de la
the
sociedad. Y
needs
ni que
of the
hablar de las
individuals
lógicas
in the
políticas,
society.
en donde sabemos
And
que con
also
cada
clearly we
cambio de
have a
gestión,
policy
con
logic,
cada administración
and
tenemos que
as
empezar nuevamente
administrations change, we
a
need to start
repensar los programas y
daily to
proyectos. El
rethink
enfoque de
the
curso de
projects
vida
and programs. The
da
life course
justificación
approach
científica sobre por qué es
scientifically
importante
justifies why it is
garantizar un
important to
enfoque de
guarantee
continuidad y de curso de vida en las
to
lógicas de
focus on the
política.
continuum of
Y esto
life in the
atraviesa también
health
los aspectos de
policies. And this also
planificación
goes
y de
across
evaluación que están
planning,
plasmadas en el
assessment
documento que
that we
elaboró
see in
OPS,
this
que es de
document
excelencia para
drafted by
entender qué hay
PAHO
detrás de todos
to
estos
understand
aspectos.
what is
Del mismo
behind all of
modo,
these
hay
aspects.
argumentos en cuanto a
Likewise,
entender que la
there are other
temporalidad
arguments
no
to understand
solamente
that the
atraviesa el
temporal
enfoque de curso
nature
de
is not
vida,
only
sino los niveles de
cross-cutting for
aplicación. O sea, que el
life
enfoque de
course,
curso
but
de
also the
vida
various
tiene
levels of
trascendencia o
application.
se
So
puede
the life
aplicar a
course
nivel
approach
individual o
may also be
poblacional.
applied
La
individually or at the
resiliencia, que
level of the
generalmente es
population.
caracterizada
Resilience,
desde el
which
punto de
is
vista personal o individual,
characterized
también
at
puede ser
the
abordada desde el punto de vista
personal or
comunitario.
individual level, could also
Las
be addressed at
experiencias
the
adversas en la
community level.
infancia, que si bien se
Adverse
originaron en estudios
experiences during
clínicos, pueden
childhood,
ser
even though
abordadas desde
they
el
were
punto de vista
analyzed in
poblacional.
clinical trials, could
Y
also be
podríamos
addressed from the
hablar
point of view of
de
the
experiencias
population, and
socialmente
we
adversas
could
en
be
la
referring
infancia,
to
tal como acontece en
socially
las zonas de
adverse
conflicto armado, o como está
consequences
aconteciendo
for
ahora durante
childhood,
la
as
pandemia del
we
COVID, en
see
donde
during
pensamos que
the
van a haber
pandemic, or
consecuencias de largo
armed
aliento,
conflict, where we know that there will
justamente
be
por haber atravesado esta situación tan particular. La
long-term
epigenética también
consequences
puede ser
because of this
abordada del punto de vista
situation.
individual, y también la
Epigenetics could also
epigenética
be
social
addressed
es
in
un
this
campo
way,
muy
and also
interesante a
epigenetics is a
entender
very
las
interesting
relaciones
field
que
to
tienen las
understand
comunidades
the relationship
y su
among the
capacidad de
various
negociación
communities and
con
their
entornos
capability to
hostiles o
negotiate in
beneficiosos.
hostile or beneficial
La ética
environments.
se puede mover también
Ethics
desde
could
la cama
also
del
be
enfermo a la ética de las políticas
moved
públicas.
from
Y
the
finalmente, los derechos
patient's
pueden ser
bed
abordados
to
tanto desde el
public
punto de vista
rights, and
clínico
also
como desde el punto de
rights
vista
have to be
comunitario.
addressed from
En
the point of view
definitiva,
of
este es
the
un
individual and
desafío
the
o
community. So
una
this is it.
invitación
Is this a
sobre
challenge
por
or
qué
is
es
it an
importante
invitation?
incorporar esta
Because it is
perspectiva de curso de
important to
vida
address
en el abordaje de la salud
life
con una
course
visión ampliada,
with an
constructiva
expanded view, constructive view,
y que atraviesa todos los órdenes
that
de
is
las personas,
cross-cutting
tanto
for
desde
all
el
of
punto de
the
vista
aspects of
clínico,
individuals, from
asistencial,
the
como desde el punto
clinical
de vista de salud pública. Cuando hablamos
point
de
of
salud
view,
pública
as
nos
well as
estamos
the
refiriendo
point
a
of
salud
healthcare,
poblacional.
public health, and we're referring, when we're
Otro de los
talking about public
argumentos sobre por
health,
qué es
to this
importante
health
incorporar
of
el
the
enfoque
population. And once
de
again,
curso de
why it is
vida en
important
salud
to
pública tiene
include
que ver
the
con el
life course
abordaje de género
approach
en curso de
in
vida,
public health
atendiendo a
is
que las inequidades
has
de
to do
género
with
comienzan
the gender
tempranamente en la
approach, and
infancia.
gender
El
inequalities do
género no es un
start
tema de las
early in
mujeres
life,
y mucho menos
during
de las
childhood.
mujeres adultas o
This is
adultas
not an
mayores.
issue that
Sabemos
pertains
que
only to women
los
and
determinantes
elder
de
women.
género
We know that
actúan tempranamente,
gender
incluso
determinants
antes
act
del
early,
comienzo del
even
embarazo, al
prior
momento de negociar la
to the
pareja
pregnancy,
la
when
posibilidad de
the
traer un
couple
niño
is
o no al mundo. Lo que ven
negotiating
a la
the
derecha es un instrumento que
capability
desarrollamos
or
para
the
la OMS para
possibility of
incorporar
having
la
a child.
perspectiva de género
Here we
en los
see
programas de
a
salud y desarrollo de
WHO
niños, niñas y
document
adolescentes.
as to how to include the
Otra de las
gender perspective.
justificaciones podría
Another
aplicarse, por
justification
ejemplo, en la
could be
reducción de la mortalidad materna. Ustedes
in the
conocen el modelo de
reduction
las
of
3 demoras
maternal mortality. You
vinculada con
know
la
this model
reducción de la
with
mortalidad
3
materna
steps
basada
to
en la
reduce
provisión de
maternal
servicios de
mortality
salud.
that has to do with the provision of
Hace unos
health
años, trabajando
services.
con
2
Ariel
years ago,
Karolinsky,
working
publicamos
with
en la revista
Ariel
Panamericana de Salud
Karolinsky, we
Pública una
published
cuarta demora,
in
que está,
PAHO's
en este caso es la
journal a
primera,
4th delay,
vinculada
and
con el
this is the
acceso a la
one that has to do
anticoncepción,
with the
y esto es
access
producto,
to
o fue producto de una
birth
investigación
control
realizada en
methods,
más
and
de
this was the
65.000
result
mujeres
of
embarazadas,
a
en donde,
trial
por
conducted
ejemplo,
in more
vimos que
than
alrededor del
65,000
50% de estas
pregnant women,
mujeres
where we saw that
llegaron a embarazo como
50%
consecuencia
of
de
these
decisiones no
women
buscadas o no
got to
planificadas. O
pregnancy
sea
as a
que hoy por
result
hoy
of
aplicar
unplanned
una expansión en el campo
decisions.
temporal de
So
análisis
when we, or
podría
unplanned
contribuir a la
situations,
reducción
so
de un 30
by
o
applying
40%
this
de la
temporal
mortalidad materna, evitando justamente los embarazos no
perspective, we could
planificados. Y en
delay
esta
and
línea de
avoid
pensamiento
unplanned
podríamos
pregnancies.
incorporar
And
otra
here
demora
we could
más,
also add another
que es
delay,
la quinta
and that has to
demora, en este
do with
caso,
the
generada a
another
partir de
delay to
las
the
actividades de
pregnancy, and has
empoderamiento
to
de niñas
do
y
with
niñas
the
y adolescentes, que
empowerment
obviamente
of
no es una
girls
responsabilidad
and
exclusiva del sector
adolescents, and
salud,
this is not
pero que nos
just the
invita también a
responsibility of the
repensar
health
cómo a
sector, but
través de
that
intervenciones
it invites
tempranas
us
podemos
to
incidir en
rethink
el
how
largo
we
plazo.
can
Es simple una
have a
idea para
long-term
meditar,
impact. This is
repensarla y una
just an idea
invitación para
to
promover la
rethink and
intersectorialidad.
promote the intersectoral approach.
El COVID obviamente
COVID
permite también analizar
clearly
el enfoque de
allows
curso
us
de
to
vida, y
analyze
lo que ven
the
acá son
life
las
course
ondas, no
approach, and
solamente
here you see
relacionadas
the
que no,
waves not only
que no
related
tienen que ver con las variantes del virus, sino con los
to the
momentos
virus
de acción
variant, but to the
de la
moments of
pandemia
action,
sobre la
the time of
población.
action in
Lo que más nos
connection
preocupa a
with
los
the
pediatras
pandemic
es qué
and
va a
the
pasar en el
population.
futuro, en
Pediatricians
cuanto a
are
las consecuencias
concerned
en el
about
largo
the
plazo de
consequences, has
pasado
long-term
colectivamente una
consequences
situación adversa
and
como la
how
pandemia
these
sobre niñas,
could
los
have
niños y
an
los adolescentes.
impact on
Y
adolescents
para
and
terminar, unas
children.
breves palabras del
And
informe Lancet,
finally,
en donde ustedes pueden acceder al mismo y leerlo, Simplemente lo que plantea
This
este
is
informe
just what
es la
we
existencia
see
de
in
grandes
this report
amenazas sobre la
and the
salud y la
existence of
niñez, unas que
threats
son amenazas
for
ambientales,
children and
otras que son
adolescents. Some of
amenazas
these are
vinculadas con las
environmental threats,
denominadas
others are
determinantes
related
comerciales
to
de la
the
salud. Esto ha
so-called commercial
permitido
determinants of
rankear a los
health. And
países
this
en cuanto
also
al estado
allowed
de
countries to
situación, ya sea
expand
por su agresión a la
their
protección del
situation
ambiente,
and
como así
study.
también las
It could be
posibilidades de
related
promover el
to
desarrollo
environmental
y el
aggression, or
crecimiento
also how
infantil desde
to
una perspectiva de
promote
curso de vida.
growth through
Lo que se sabe es que ningún país del
through
planeta
the lens of life, of the
satisface
life course.
ambas
But no
aspectos. O sea,
country
que aquellos países que contaminan el
satisfies both
ambiente,
aspects. Those that
llamativamente
are
dicen los que tienen mejores
polluting the
recursos
environment
para
are the
promover el
ones that
desarrollo y
have
viceversa.
fewer resources to promote
Cuando hablamos
development.
de
And
determinantes
so when we are
comerciales,
referring
estamos
to
hablando de
commercial
aquellos
determinants,
productos
we
que
are
son
referring to
lesivos para la
those
salud de la niñez
products that are
y que tienen un impacto,
detrimental to the
obviamente, en el
health
largo
of
plazo.
children
La
and that
pregunta que
do
uno se
have a
hace es
long-term
qué relaciones tienen
impact.
estas
Our
amenazas
question
con el
is,
enfoque de
how
curso de
could
vida.
these
Y
threats
se
be
sabe
related
que las
to
amenazas ambientales
life course?
son muchas
And we
mayores
know
sobre la
that
población
many
infantil y
of these
adolescente. Y
environmental
con respecto a las
threats
amenazas
are
comerciales,
higher among
se
children
sabe
and
que las
adolescents. And
empresas
as to
saben
commercial
mucho
threats,
del
we know
enfoque de
that
curso de vida
companies
con
do
sus
know
estrategias de
a lot
marketing
about their
para
life
promover
courses
la
through their
adherencia, la
marketing strategies
fidelidad,
to promote
y hacer que
brand
los chicos y chicas
loyalty and also
consuman
have
productos desde etapas tempranas de
youngsters
la vida con las
consume their
consecuencias, por
products
ejemplo,
early in
en la
life
aparición de
with
enfermedades
the
crónicas no
consequences
transmisibles.
of chronic
Y ahora
diseases
sí,
or
para terminar, el enfoque de
non-transmissible
curso de vida es
diseases
un
later
campo de
in life.
integración en
So the
salud pública,
life course
ya que
approach
contempla la dimensión temporal,
includes the temporal
incorpora el reconocimiento
dimension.
de las
It
inequidades
also
tempranas y
includes the,
tardías y la
the early
reproducción
recognition of inequalities
intergeneracional
and
de las
also the
inequidades.
intergenerational
Permite
reproduction of all of
identificar
these
los factores de
inequalities. It also
protección y los
allows
factores
us
de
to
riesgo
identify
en
protection
cuanto
and
al
risk
modelo de
factors as
acumulación
to
que trata
the
de explicar el
accumulation
enfoque de curso de
model that
vida.
attempts to explain
También
the
incorporo acá en
life
este
course
gráfico que
model.
no
And
estaba en el
here in
original,
this
que es el
graph,
fenómeno, el aspecto de diversidad que
we
hay que
have
tener
the
en
aspect
cuenta
of
como un elemento
diversity that has
diverso
to be
que
taken
hace a
into
nuestras
account
sociedades que debe
as
ser
the
reconocido y
diversity in our
valorado.
community that has
Y
to be
finalmente,
recognized. And
el
finally,
paraguas de los
the
derechos que tiene que atravesar de alguna manera y estar
rights
garantizados por los
umbrella
estados
that has to
a lo
be
largo de
guaranteed by
todo
all of
el
the
curso
states
vital.
throughout the life course.
Le pido disculpas a las personas que hicieron
I
la traducción por la
apologize to those
velocidad
who
de mi
had to interpret
presentación.
me because
El
of
informe
the
está disponible
pace
para
of
ser
my
analizado
presentation, and
y
this
estoy
report
dispuesto,
is here to
obviamente, a
be
participar en la sesión de
analyzed,
intercambio. Muchísimas gracias.
and we can also exchange our comments regarding this. Thank you very much.
Excellent presentation illustrating some of the concepts presented by Dr. Forrest and bringing in some other elements such as equity and rights and re-emphasizing the importance of seeing health as a continuum across the lifespan and not as a snapshot. Without further ado, I will introduce the last speaker of this block, which is Dr. Wilson Ware from WHO. Dr. Ware, the floor is yours.
Dr. Ware, you need to unmute your microphone.
Are you able to see my slides?
Yes, we can see your slides. If you can put it in, perfect. Yeah.
Is okay?
Yes, perfect now. Thank you.
Thank you very much. I think this gives me a lot of background that has been presented by Dr. Forrest and Raul Massey. I think they have provided the justification why we should take a life course approach. But as we look behind what has happened over the years, we have a lot of frameworks. I think as Raul Massey has said, we have the global strategy for women and children's health. We have looked at determinants of health, nurturing care, the AHA for adolescent health, and now looking at all this information, what does it mean as we progress to address the child and adolescent health and well-being? And that's what I really want to focus on. The framework provided for us is around survive, thrive, and transform. And I think we need to ensure that all these three components are addressed within the programming for child and adolescent health. And that is really the focus of this redefining of the new agenda we are talking about, in line with what has just been clearly well explained on why the importance of life course approach. And so what does this mean as we move forward? Over the years, with the focus of on reducing mortality, we have sort of narrowly focused on health without looking at the whole span of health and well-being. However, after looking at this, we have realized that even while we have really made progress in reducing mortality, actually non-fatal disease has not changed for a very long time. And of course, the causes of mortality and morbidity are shifting and the priorities are changing. And we are already seeing a lot of non-communicable diseases becoming a big issue. The other thing is really that most of the things, even when you are looking at the survival agenda, we need to start really looking at what are the social determinants that we need to address beyond the biological factors of health and well-being. And also the need to ensure this continuum that you are able not only to make children and adolescents survive, but to be able to build their resilience by addressing and buffering different adversities that they go through, like has been explained. And this has a lot of implications when we come to programming. It's really now to really look broadly in health and well-being, look with the concept of life course approach, like has been well explained across the 2 decades of life, and looking at services being delivered in terms of an ecological approach. And I think it was very well explained by Dr. Forrest in terms of that the children and adolescents are interacting with different environment factors, and we need to look at that. And that also means that we should look beyond just looking at health. If the health sector as the only sector that can address health and well-being of children and adolescents, we need to look at other sectors that will contribute to this. And therefore, that means we have to redefine the goal of the health and well-being. The goal should be really to ensure that every child and adolescent 0 to 19 years of life is optimally healthy and is raised in a safe and secure environment that is appropriately prepared. And I think that was well illustrated in the first talk. It's really physically, mentally, and socially and emotionally able to accomplish what they are supposed to accomplish by the time they reach as an adult. And I think this is very, very important. If we base our programming towards achieving that goal, then we should be able to really put the life course approach in a real perspective in programming. So what does that mean now as we move towards this thinking? One is really we need to extend the predominance of programs from survival to really extend it to cover areas around not only health, but nutrition, psychosocial support for the whole to the decades of life, which are very critical, which predetermine the future, and refocus the agenda also to address very specific things. And I think this is very, very important. It's not that we just talk about the life course approach, but I think it's also very important that there are various timings that we need to look at, make sure that we are able to address any major vulnerabilities that the children and adolescents might have, and particularly during the transition periods, which are very critical for their growth, health, and development. And also the most important is how do you build, we need to build their resilience. I think this is very, very important through promoting their health and addressing a lot of morbidity or this lot of complexities, like it was said, that they go through. And in order to do this, then we need to make sure that we have really comprehensive delivery of interventions that are centered, and the programming is centered around the child and adolescent, not around disease, not around immunization, but really, how do you program around these children? I think this slide, I just wanted to illustrate what this means, but I think we have had very good presentation on that. But just to highlight that it's very, very important to realize that we can act and correct the trajectory. And I think this is very, very important. Secondly, also to say that the gains that we have got in the previous can actually be very maintained by us doing and making sure that we are able to maintain the course the children are taking on and trying to correct it when there are issues. And that is really very, very important. In order to do this, I think it's very important to say what are then the domains that we need to consider in programming. And we have come up with 6 domains, really looking at where are the areas where you can take action. One is around ensuring good health. Another is ensuring adequate nutrition. Another is responsiveness and relationship and connectedness. And this is very, very important depending on the age of the child or adolescent. There are various aspects that must be undertaken to achieve this. Ensuring security, safety, and supportive clean environment is very, very critical for the children. And opportunities for early learning and education is also very important. And as children grow, there's really the need for realization of personal autonomy and resilience, making them adaptable, like it was said, to the society and to be able to achieve their goals is very, very important. So these domains really are very critical if you are considering, say, well, how do I intervene? What are the actions I need to take in the program to actually to ensure this life course approach programming? Just an example is to say that it is also very important to say that there will be interventions that should be universal across, irrespective of where the child is, whether they are poor, rich, vulnerable or not. These are interventions that should be universal because they are necessary for their health and well-being. However, we should also recognize that there will be need for interventions that will be very situational and more specific for individual children, other than just looking at universal, but saying, for example, if a child falls sick, he will need to be treated so that you can correct that issue. If a child has some issues around, he has been screened, has, for example, metabolic diseases, or has a chronic disease, or has a disability, these children we need to optimize their health. And I think that's the most important thing. We have to support them to optimize their health. And then there will be vulnerable children that will need social protection. So in addition to universal interventions, we need to do that. But how then do you see ourselves providing this? This is just an example of a matrix looking at those domains and saying, what can you do at different stages of life, building on each of them as you go ahead. And this is something that we need to think of when we are programming and how do we package our interventions and look at them, and also realizing then who is best suited and when are these interventions supposed to be best delivered. And these are the most important things as we go towards programming for child and adolescent health and well-being. The other aspect, and I think this was very much well highlighted to consider in this, is really where are we going to take action? And I think it's very, very important that, and I think it was very well illustrated in the first presentation, saying that really the influence, the complexities in which these children live is what determines their health and well-being. And so the determinants are very, very important because they're embedded within the families, within the communities, and within the environment they live. And in order to support them and take actions, we need to consider that and make sure we have supportive laws and policies and regulations in addition to the interventions we are going to provide. And that also brings me to the next issue that needs to be considered, that this has to be a multi-sectorial approach. That means that health sector only will not be able to deliver health and well-being for children. We need to look at education, because as you know, once children go into school, they probably spend half of their life in school. And if you are going to do anything for them, you have to do something for them when they're in school. But also we have to remember that there are children who don't go to school, and we need to see how to address them. There are issues around child social protection, because poverty, vulnerability, children in humanitarian settings will need our protection. And in other words, you need very different actors in order to provide it. You need good food, you need water and sanitation, the environment, housing, injuries, you need to talk to different sectors. And all these sectors have to come and play a big role into the programming. And this takes me back to what I said. The goal should be that you look at how can we achieve optimal health and well-being of the child, and what can the different sectors contribute to. And I think this is one of the challenges that programs will need to address. What is the contribution of the health sector? What's the contribution of the education sector towards achieving that goal that we want to achieve for the optimal health and well-being of the child? And lastly, what are the different program requirements? I think this is also very critical, that as we think of programming, we need to look at what do we need in order to achieve this. If we are talking about whole government approach, then you need a lot of advocacy, because it will not come by somebody has to catalyze it. If health catalyzes whole government approach or health policies in all sectors, this has to be a central role of advocacy and creating an enabling environment. So you need leadership and governance that will support that mechanism. And that will also require financing and building partnerships around all the agreed actions that you'll have to take. At the end of this, you'll also realize that then you need many different providers in order to deliver some of the interventions. It's not only health workers, you might need social workers, you might need educators, you might, many different people will contribute, even people in law and justice will have to contribute. And how do you coordinate all these mechanisms? And I think this is very, very important to ensure that there's continuity between different sectors as you organize your programs. And then you have to be clear on what are the packages that and pathways of interventions that these children and adolescents will require. And what are the supportive tools that can do this? For example, if we are going to talk about life course approach, we need to ensure that there are records so that you can know exactly what happened, what adversities were there, what was corrected, what has been the trajectory over time. And this requires us having and redesigning records, individual records that are very important for everybody to have access to, not only the providers, but also the individuals themselves. I think it's very, very, very important. And also to make sure that we are broadening our understanding, that's not really focusing on the individual, child and adolescent, but also what does the community need to be enlightened in order to provide the best environment of growth and development and well-being for adolescents and children. So these are some of the things I just wanted to share. In summary, I've just given an overview of and highlighting areas that we need to think about as we go to redesigning the child and adolescent health and well-being program. Thank you.
Thank you so much, Dr. Ware. I think these three excellent presentations really tied into each other and build on each other, walking us through from concepts and constructs to application, interpretation, and implications of the life course approach with a focus on the first 2 decades of life. Once again, thank you, Dr. Forrest, Dr. Mercer, and Dr. Ware, 3 excellent presentations. I want to welcome the persons who joined us during the last 3 presentations. Welcome to this webinar, and also those who are following this webinar through YouTube. As we mentioned at the beginning, we don't have a Q&A session, but please, comments, you can use the chat to put in your comments, share your comments, and also a Q&A, use the Q&A button, and we will try to respond to your questions as we go along. So with this, we end the first block, and for the next block of this webinar, I would like to introduce my colleague, Dr. Pablo Duran, who will be moderating the panel discussion. Dr. Duran works at the Latin American Center for Perinatology. We know it as CLAP in our region, as the regional advisor in perinatal health. His scope of work is in the area of perinatal and neonatal health, health of the newborn, coordinating with other areas under our Department of Family Promotion and Life Course. Pablo, over to you.
Thank you, Sonja, for your kind presentation, and thank you, colleagues, for the excellent presentations. Now I'm going to switch into Spanish.
And also, I join the comments of the pleasure of being able to participate in this webinar today. And now I will moderate the panel that will deal with the implementation of the life course approach based on what we just heard from the presentations we heard earlier. The speakers we have for today in this block will share their experiences and interventions which are quite relevant for the development of children and adolescents and have implications not only during the first years of life, but that the benefits of these interventions extend, as we'll see and as we know, throughout the life course. We're going to begin, and it's a pleasure to introduce Dr. Natalie Charpak, who will talk to us about the Kangaroo Foundation, the Kangaroo Method, and the importance of this in the development of prematures in the context of the life course. Dr. Charpak is a pediatrician, currently scientific coordinator of the 3 Centers of Excellence of the Kangaroo Method in Colombia, and is also a founding member, a senior researcher and director of the Kangaroo Foundation in Bogota, Colombia since 1994. An NGO dedicated, as many of you know, to research, teaching, training, and medical care related to the care of the kangaroo mom, specifically for prematures and children with a low birth rate. The Kangaroo Foundation has done very important research and clinical trials and contributions on the method, actively disseminating the Kangaroo Method, mainly in the low-income and middle-income countries in Latin America, in the Southeast Asian countries, Eastern Europe, and so forth. After Dr. Charpak's presentation, we'll hear from a nurse, Nicole Garay Unidos from Chile, who will talk to us about the Chile Grow With You, Chile Crece Contigo, which is a comprehensive protection system for children in Chile, whose main role is to support and comprehensively help girls, boys, and their families through actions and services offered universally, as well as focusing on specific supports for those who have greater vulnerabilities or special conditions. Nicole has a master's in infant mental health and is a professional of the National Health Program for Infants and Chile Grows With You, depending on the Division of Disease Control and Prevention in the Public Health Division of the Health Ministry in Chile. And lastly, and then we'll hear the presentations, Dr. Susan Sawyer, who will talk to us about the positive development framework of adolescents and the results of this for the health, behavior, and development. Professor Sawyer is in the health chair for adolescents in the University of Melbourne, director of the Health Center for Adolescents in the Royal Children's Hospital. Dr. Sawyer has been a consultant of the World Health Organization, UNICEF, UNFPA, and the World Bank, and has been co-director of two recent series on health of the adolescents for Lancet, and is a commissioner of the Health Commission of the Health and Welfare of Adolescents in Lancet. With no further ado, I'd like to invite Dr. Natalie Charpak to do her first presentation. Natalie, you have the floor.
Perfecto.
Can you see my slide? Well, thank you very much for this invitation. This presentation is in English, but I am going to speak in Spanish on the long-term impact of the Kangaroo Method. After hearing what I heard this morning, I really understand why the Kangaroo Method fits so well into the children's life course. So what is this Kangaroo Mom? The Kangaroo Mother Method, if you give me a second, I'm trying to fix these slides. The Kangaroo Mother Method is that the kangaroo has three components. It's a kangaroo position, kangaroo nutrition, and early outlet in the kangaroo position at home or in a kangaroo shelter with very strict follow-up until the child is 40 weeks old. And then it has a high-risk follow-up program of 40 weeks to 1 year. So who is this Kangaroo Method for? For all premature babies and children with low birth weight. The kangaroo position. Let's talk about the kangaroo position, which must begin very, very early as possible, and for as long as possible. First in the hospital and then at home after she's dismissed from the hospital. Here you have some pictures. You can appreciate the routine kangaroo in a unit. It's with special chairs, the fathers, the mothers. During the pandemic, there was only one person allowed, and they choose mother or father depending on what's going on with the COVID. Here you see, and I'm going to talk about outside of the pandemic. This is a band, and I think it's important that I mention one specific aspect. We never take the baby out of the kangaroo position. He asks to be taken out, usually around the 38th week in Colombia, when it's about 2,500 grams, the child begins to want to come out of the kangaroo position. This is a 5-star kangaroo. I don't think you can see the titles, but it's okay. I'll just read them to you. This is the 5 stars kangaroo, which is a child intubated in intensive care, and the mother and father spent between them 24 hours. That's in Sweden. Here in Colombia, in the university hospital, the same. You see these chairs that have arms. The mother has a blanket. She has the girdle-like effect, and it's 24 hours. It's open 24 hours a day. If you don't open the neonatal, you'll see the 24 hours of parents' presence. Otherwise, they won't have maternal food or the kangaroo position because there are limitations. You really have to open the unit. Here, you can see some lovely pictures. I like to show them because it shows how the mother's being taught to manage her child. And by the 3rd day or the 4th day, the mother is an expert and will be on support for the nurse. Here you see how the father participates as well. And it's very important, as I'll show you in the 20-year results. The father must be invited to participate in the whole process. Here you see the blood sample in the kangaroo position. It's not that it's not going to hurt the child, but it's going to hurt him less. And the child is sucking from the mother's breast and thus recovers much faster. And the integration with the siblings, the kangaroo nutrition based on breastfeeding, that is indispensable. But in order to do it again, you must open the units again. I would say that this kangaroo method is even harder than the kangaroo position. The mothers have to be taught how to breastfeed their children and their twins. And that's very difficult. To breastfeed a premature baby is an art, and it's difficult to teach it. And we have to decide to do it knowing the benefits of breast milk. And even the most immature babies, I know it's difficult to jump from the catheter to the direct suction. I don't think this is the time to talk about it, nor to have a 30-week-old child on the breast of the mother is easy, but this is an important component for the child's development. After that, you have the departure once the mother is dismissed from the hospital. In Colombia, what is customary from way back in the kangaroo position with very close follow-up. Of course, there are eligibility criteria to discharge mother, the mother and the family. Here you have pictures of discharge and follow-up that I show you because there's nothing more important than education. The parents are educated to carry their child and for all the things that they're going to be doing during this first year of life where they follow the ambulatory kangaroo program. They're taught how to deal it. We make adolescent workshops, the grandparent workshops. The idea is to take advantage of the fact that they're here to train them, to teach them, and the parents participate, the father participates in this. And you see the same thing in other countries. This is life at home. You see the father arrives after work, carries his baby. I took these pictures. I don't have a camera, but I do find these pictures to show the mother's pleasure when the father comes in and helps her and gives her a rest to do other things. Here you have 3 brains, and I'll tell you why I show you this. Look at this one, it's smooth. Look when it reaches term, 25 weeks, and see a term baby. This is our responsibility here when the child is premature, when this premature child is in our hands, we're trying to develop it. Here, during this period during which the child is with us, the volume multiplies 1.5 times the surface of the brain times 4. And I'm not talking about growth of the axonal area in the 3rd trimester in the synaptic connections. It's here where the kangaroo works. Now, I simply call it the brain surfactant so that it's really clear that you understand what this brain needs. The kangaroo begins at birth and goes through the unit, then at home, and with the follow-up. This is a kangaroo mother program. One can do it at birth with resuscitation if necessary. You do the resuscitation in the kangaroo position. You can transfer even to another hospital. The mother may be discharged or sent to a special ward, or it can be done in the intensive care unit or even in the intermediate care. The kangaroo must be a routine, particularly to protect the child's brain. The brain grows thanks to the sensorial stimulation of the mother. We do the same with the smell, with the voice. It's like surrounding the child with the adequate environment for his development. We, between 93 and 96, did a randomized study and we published the results term and after 1 year, showing the results for the morbid mortality, growth, development, and other outcomes were at least as good as or even better than those obtained with the traditional care. And we asked ourselves, of course, then, if this persists after 20 years, are there long-term effects of this kangaroo method? This was a study we did with Grand Challenges in Canada and another 6 universities in Colombia and in Canada. And In terms of mortality, definitely the result is positive. We see less than 1800. Clearly, the kangaroo effect, as we know, has a protection effect against mortality. The same for the long-term results. And then we found a very interesting thing with the paternal participation. We showed that there was a interesting relationship. If the child is present and is involved with the child's development, and what happens 20 years later, there's less divorces in these families. We also studied, according to the level of education of the mother, the 20-year impact on what we call premature sequelas, hyperactivity, antisocial behavior, aggressiveness, internalization, and we saw a definite impact. And then we studied a very cute thing, which is that the kangaroo mothers send their children to the daycares before. There's less dropouts, the number of years of school, but curiously, the kangaroo children gained a bit more, and more than one was continuing to study. We saw their IQs after 6 months, 12 months, and 20 years with repeated analysis. And we saw the home environment after 12 and 20 years and showed that the weakest children during the first years and the protection we have found persisted up to 20 years. We also studied some interesting factors which can have an impact on the child's IQ over 90 or less than 90, the growth of the child after a year, the head circumference, the feeling of competence of the mother after 40 weeks and a year, and the quality of the family environment. All of these have a tremendous impact on the child's IQ at the age of 20. And finally, the gray matter, the volume of the cortex, the volume of the basal nuclei, and the subtopical gray matter. What does this mean? What does the kangaroo method mean? Of course, you have an empowerment of the parents who work enormously to get their child ahead, and they become more sensitive to the child's needs, not only during the first year, but even after that, even when they're young adults. There is an interaction allowing them to cause an almost anatomical protection, allowing the brain to mature ex utero. Thank you very much. I can say that it takes a lot of time to transform a new idea into a reality, and you find a lot of resistance, but we must continue to work so that it becomes a routine in all neonatal units. Thank you very much. Thank you, Dr. Charpak. Excellent presentation showing us in practical way and the long-term impact of this concrete approach. What we heard from the first block and what we talked about, the implementation of the context of the life course. And now we're going to give the floor to our next presenter in this block, Nicole Garay Ullidos. Nicole, please. Are you there? There you go.
Acá estoy.
Ay, muy
Muy
bien.
buenas. Acá estoy. ¿Sí me
Thank you.
escuchan bien?
Can you hear me? Yes. Very well. Good morning to all of you. And we want to thank you for this invitation. And I want to tell you that it's a pleasure and an honor for me to share this experience with you today. I'll begin my presentation within the framework of Sustainable Development objectives and what was mentioned in the other presentations of placing children and adolescents in the center of our actions so that every country can achieve a better development for the next years. As mentioned, we know that research in development have highlighted the process through which children and adolescents achieve the cognitive capacities, social, physical, emotional capacities, which are fundamental for school education as well as for economic productivity in their adult life. The life course approach allows us to have a comprehensive approach in health, which is considered the result of dynamic interactions between the exposures and events of the lifespan, which have a cumulative effect and have an impact both negatively and positively on the person's trajectories. Investments and experiences during first infancy create the phases for success in all life. Threats to children's health and welfare may have to do with the health determinants, and you need a multi-sectorial approach to ensure that children and adolescents enjoy a comprehensive development presently and in the future. Intersectoral actions may be diverse in different countries, but they require strategic associations, coordination with the ministry and the different partners from the private and public sectors. In Chile, the National Health Strategy is the roadmap through which we establish health priorities to advance sustainably in achieving the objectives established for the decade. In the 2011 to 2020 strategy, the strategic objective number 4 establishes the life course approach. And we see that there are several, but in the center, we see the life course. It says vital cycle, but we've changed it to life course to reduce the mortality, morbidity, and improve the health of persons throughout their life trajectory. As we know from objective number 4, we have infant health, and the idea is to favor development and reduce the backwardness of children under the age of 5 through these health programs, and Chile Grows With You is promotion of infant development. Our country has primary health care, which represents the foundations of the health services with a family and community approach and a life course approach in order to empower the children, people to make decisions and to support their development trajectory from gestation to the development of the adult in the primary level through different health devices, highlighting the family health centers amongst them. In these centers, the health professionals, like nurses, physicians, and midwives, to offer different types of services, which we can mention, and you see them on this table: consultations, prenatal workshops, infant health control, support. All of these are part of the program aspects of the health programs of women and the infant programs, adolescent programs, as well as a cross-cutting ones such as mental health, nutrition, immunizations, oral health, and others. We also include the comprehensive protection in the Chile Grows With You program, strengthens support in the infant development trajectory since gestation up to the age of 9. Through the program, the PAHO program, the Access, which is the development of the psychosocial, and the support of the newborn program and the infant mental health program, which we know here as PASME. And then through the law 20,379 promoted in 2009, the social protection intersectoral system is created and institutionalizes this comprehensive care of infants in the Chile Grows With You program. The social protection system is a management program that was set up by social actions implemented and developed by different state agencies directed to the most vulnerable populations who require a concerted action from these agencies to have access to better living conditions. The system has 3 subsystems, including the safety and opportunities in Chile, which is to contribute so that people and family can overcome their extreme poverty situation sustainably and reach better living conditions. The second is the Chile Cares, and is a program of the support networks with protection and comprehensive care of persons with dependencies. And the third is the Chile Grows With You subsystem, which is the comprehensive system of support during infancy as one which supports children and families throughout their trajectory of life. The Chile Grows With You has three components: the health component at the Ministry of Health, the social component through the Ministry of Social Development and Family, and the educational component in the Ministry of Health. However, it is the Ministry of Social Development and Family that coordinates, articulates, and monitors the intersectoral actions offered by this subsystem. Furthermore, the subsystem is implemented at three levels: nationally, at the level of ministries, of course, regionally, with representations in the CDMs, which are the regional health secretariats or development secretariats and education secretariats, and through a more local one, which is the community level, where they develop the role of Chile Grows With You at different levels, coordinated to support and satisfy some of the, or help with some of the vulnerabilities and some of the risk factors, detecting them, responding to them as they are detected throughout the lifespan. The comprehensive children's subsystem is to, as I said at the beginning, support, protect, and help all children and their families comprehensively through different actions and services of a universal nature, and focusing on special supports required by children having greater vulnerabilities, using the slogan Chile Grows according to the needs of the child. The children are integrated into the subsystem of Chile Grows With You when the mothers go to the first pregnancy control in the public health system. And that's when the personalized support begins, reaches the first cycle of basic education. Here, I leave that link where you can see it if you want to access more information. Chile grows with universal and specific actions, as I mentioned. Amongst the educational aspects we have here, universal actions like these education programs that have a web page, radio programs, where experts are interviewed. There are social networks that are followed by thousands of people in Chile with different educational levels that are constantly updated with the participation of key actors at a community level as well. Then we have more specific actions for children in the public health system, such as these three programs that I mentioned before. The main one is the Biopsychosocial Development Program, where we also detect risks and alarms of vulnerabilities so as to activate warning signs so that the other ministries can respond to this as well. And finally, we have the children with vulnerabilities, which are 60% of the most vulnerable, who have preferential aspect of shelters, daycares, family visits, family subsidies, assistance to children that have delays in their development, and others. The health component, as mentioned before, covers from gestation to the 9th year of age, and it is the Biopsychosocial Development Program. This is the main program, which is the entry point to the system. Through this, we strengthen the children's care, children's development, evaluation of risk factors, evaluation of neurodevelopment, evaluation of the presence of pathologies, mothers who could have an impact in the development curve of the children. And through the different things we add to the program, we promote positive breeding, respectful breeding, to strengthen the parents' skills as optimum for the development of children. We can see that there are things that are done at the primary care level, others at the hospital environment, and we have today only this program of support up to the age of 4, but for the group of 5 to 9, we have the mental and infant mental health development program. And to end, I'd like to mention that through the service catalog, Chile Grows, we have the actions of each one of the three programs, which are modified and updated according to evidence received and the national context. This is the catalog we have now of the services offered, and we adapt them to the pandemic, in fact, so you can review that as well in greater depth in the webpage I mentioned before. And to end, the development and welfare, it has an impact through different factors and experiences in the case of children. Continuous positive experiences and relationships with other people, like the parents, caregivers, are essential for this optimum trajectory through Chile through its health programs, strengthened by the Chile Grows With You program, supports life trajectory of children, and the parents can have parental skills that can have an impact on the life course of the children and can detect vulnerabilities, which are risk factors that could have an effect on the development of the children. We add to this intersectoral actions, which are coordinated by the subsystem in order to give a better context to the children. That's my presentation. Thank you very much.
Excellent, Nicole. Thank you very much for your presentation. Another clear example of implementation in policies, actions at the intersectoral level that reflect the life course approach. Now, without further ado, I'd like to give the floor to Dr. Susan Sawyer.
So thank you, and the floor is yours. Over to you.
Good afternoon to you all. I'm speaking to you from Melbourne, Australia, land of the kangaroo. And so I was delighted to hear Natalie's presentation in particular, but also just thrilled to hear the synergies and the flow of the presentations across the day. The team at PAHO has asked me to speak on adolescence within the life course, and particularly to talk about a couple of aspects of what we think of as positive youth development. But I want to take you back to the end of the Millennium Development Goal era to start with, because during the MDGs, there was really no focus on adolescence at all. But coming to the end of the MDG era, across the 4 years of the last 4 years, we had 4 important reports from UNICEF, from USAID, UNFPA, and then WHO that were all focused on adolescence. We then had, leading into the Sustainable Development Goal era, the launch of the new global strategy for women's, children's, and for the first time, inclusive of adolescence. I've been privileged enough to be part of the Lancet Commission on Adolescent Health and Wellbeing, which coincidentally was born in early 2016, right at the start of the Sustainable Development Goal era. And in terms of this report that brought together about 27 experts from across the world, including the United Nations system, and including young people themselves, academics from many different areas of science, public health, medicine, and young people themselves, we really pulled together a narrative which tried to highlight the importance of adolescence and thinking about the different strategies for intervening. I've pulled out this quote from Ban Ki-moon, the then UN Secretary General, about young people being our greatest untapped resource, that he wrote for an accompanying editorial, that I think is a very powerful way of thinking about the energy of young people and what they can bring within their own individual life course, but within their countries as well, in terms of the potential to be reaping the demographic dividend when we get those investments right. And then I've also highlighted the quote from the front cover about this generation of adolescents and young adults being able to transform all of our futures, and there being no more pressing task in global health than ensuring that they have the resources to do so. And if there's one thing I'd like to leave you with is thinking about, well, what are the resources that young people need? Ideas have changed. Christopher Forrest at the start of this session highlighted some of the changing ideas that have led to different ways of thinking about the life course. And our ideas about adolescence have also changed. Being previously considered a very brief, inconsequential period of turmoil, a time to be got through as quickly as one could, to this current appreciation of adolescence as a foundation for future health. And this definition that is, I suppose, in some ways, my definition, one that we sort of used in the Lancet Commission, but adolescence is this profound period of human growth and development in which the assets and capabilities that underpin future adult health, social relationships, parenting, employment are established. An incredibly important period of time that has been incredibly neglected. I'm 60. And when I was at medical school at the University of Melbourne, I was a good student. I learned nothing about adolescence. When I did my pediatric training at the Royal Children's Hospital, an excellent children's hospital, the best in Australia, I learned virtually nothing about adolescence. And yet here I am talking about what a profound period of human growth and development it is. It is striking how little research there is about adolescent development. What most of us did learn at medical school was about the importance of puberty. But what we learned about puberty was the endocrinological aspects of puberty rather than the impacts of the brain development that takes place that leads to pubertal development and then is also responsible for the most remarkable changes in the brain that are really second only in terms of the intensity to the first 1,000 days in life. This is this remarkable period of time that if we get the nutritional, physical, social and cultural milieu right for young people, then they can, in terms of how those brains are developed, building on earlier development, young people can finish into their mid-20s with a high level of cognitive capabilities, really being their smartest, fittest, strongest, fastest that they will ever be. But that will take a series of investments. We've heard from speakers earlier today about the importance of the social context across our lives, across the life course. And I've really just thrown up here the social context across adolescence itself, which I've highlighted here in the slightly darker panel. And really highlighting how dynamic, how changing is the social context across adolescence. In the pink bar across the bottom, family is stable, arguably, but family changes. We move in the adolescent years from family of origin to the orientation to forming one's own family. There are dynamic transitions between education and employment across the adolescent and young adult years. And the importance of peers and the importance of the ways in which that peers shape our own behaviours as adolescents. And I've put up here media, if you like, as a super peer, an uber peer. There is no other time in the life course that the social influences on our individual behaviours are as strong and as influential as the adolescent years. In the Lancet Commission, we talked about the importance of, what's happened here? Let me just see if I can pull that back. Sorry about that. In the Lancet Commission on Adolescent Health, we talked about the benefits that come from investing in the triple dividend. We had on the horizontal axis of what I call the butterfly diagram, we have the life course here starting from preconception and heading through to adulthood. And we talked about how in adolescence, what we are needing to do is to match the actions, health actions in terms of actions around health services, community actions and structural actions to the health needs in terms of problems, risks and determinants that young people have. And I tend to think of this as the butterfly with those wings coming together and the body being the life course. But the triple dividend that we describe talk about when we are making investments in adolescence, that they pay off during the adolescent years themselves, the first dividend, with, for example, fewer deaths by accidents and injuries, the biggest killer, the most fatal burden of disease, particularly in males. But when adolescents make healthier choices, for example, decisions not to smoke, framed very much by the social, taxation, legal frameworks around them, then if they become, for example, non-smokers as adults, it's one of the healthiest decisions that they can make in their life course, so that there will be less premature death in adulthood and healthier as they mature in age. And then the third part of that dividend is then in terms of being older and more educated and making healthier choices that will hugely influence the next generation. Many of us in pediatrics think of adolescence as the end of childhood. But when we view adolescence from an evolutionarily developmental perspective, we can see that adolescence is actually the start of the next generation rather than the end of childhood. In the the Commission, we really talked about needing to think about a broader range of elements that constitute adolescent health, rather than just a focus on sexual and reproductive health or HIV, which has been the predominant health issues that have been the focus of interventions, particularly in terms of mental health. And I think that COVID has absolutely brought this home in terms of the significance of mental health. And when we look at the data, looking at different age cohorts and how mental health has been affected across the pandemic, that the striking increase in terms of depression and anxiety has been most profoundly experienced in the young, in adolescents and in young adults. And we need to be thinking about moving not just in terms of thinking about responsive clinical systems, but also really trying to think about prevention as well. We have new views on responsibility for adolescent health in terms of multiple sectors being involved, as Wilson was highlighting. And in the Lancet Commission on adolescent health, we really talked about education being the most important investment that we can be making in terms of promoting the health and well-being of young people. And I want to talk for a minute about positive youth development, because really wanting to highlight that it is the developmental experiences that are provided during adolescence that of themselves then provide the optimal preparation for the attainment of adult potential and well-being. And as Karen Pittman, this very well quoted comment that problem-free is not fully prepared for adult life. I was involved in a very complex and large systematic review of over 25,000 papers of the notion of positive youth development programs in low and middle income countries. And we put together this conceptual framework that Rico Catalano led, which was really framed around looking at where these papers sat in terms of whether they focused on building assets, on building agency, on building opportunities for engagement and contribution, or in terms of framing and changing, enabling environments, both social environments as well as physical environments and attitudinal environments. And again, really focusing on gender as a very important one of those. If you think about the ways that we think about parenting of young children, if we think about nurturing care frameworks that WHO has very much promoted, this language that you're seeing here, and I'm not going to go into any of the programs that we talked about, but the language that you can see here in programs that were aiming to be growing these features is a completely different language to the language that parents of young children learn about. It is many of those same elements brought through, but applied in a very different way. This is not what we do to adolescents, but what we do with young people, how we build their capabilities. I really also then want to highlight that more recently, WHO and a broad UN group has come together to really define adolescent well-being, framed here as the definition where adolescents have the support, confidence and resources to thrive, where they can develop secure and healthy relationships and realise their full potential and rights. And apart from the focus on good health and nutrition, those of you who look at these headings and think that there's a lot of similarity with my last slide are right. And when just last night in putting these slides together, I sort of looked at these and thought, well, where do these overlap? And I was sort of really trying to pull these two frameworks together, and I've just put these formal definitions up. These are remarkably similar frameworks that are really talking about the same thing. One might be much more focused, if you like, on the present, the adolescent well-being framework, whereas the positive youth development is developing these assets in terms of moving forward into adult life. It's much more a life course perspective. But if we think about going back to the notion of the Lancet Commission and the triple dividend, we can see how this comes together. We need to be making investments to be promoting the health and well-being of young people now as young people, but also in terms of supporting their future lives. Next week, WHO and UNESCO are launching new global standards on health promoting schools. And this is a sneak preview of these. Wilson, you're not allowed to let Valentina know that I'm sharing this with the audience at the webinar today. But I think it was really just wanting to frame this, show this schema with you about these new 8 global standards, to be reinforcing the comment I made earlier about the seminal importance of schools. I can't remember which of the speakers earlier said that young people spend half of their waking lives at school, and trying to better equip schools as communities, just like we try and equip families as a social environment where family environments are ideally safe, are engaging, are learning environments where young people are able to be themselves and be their best selves. So too, we need to be ensuring that education systems are owning the role they have in promoting health and well-being. And a key feature of these global standards is that these are primarily owned by the education sector. This is not about what we in health do, using school as a platform for delivering programs, however important and valuable those programs might be, but rather it's the evidence base that we need to be bringing about whole school approaches, about alignment across schools, and recognizing when we get the building blocks of positive youth development, together with a focus on the programmatic interventions that are aligned across schools, then we are both achieving the best learning outcomes as well as the best health outcomes. And I would just simply use the example in terms of the intertwining of health and development to say that we know that children who go to school hungry are not going to be able to learn, just like we know that children who are overwhelmed by anxiety disorders or depression, a health context, are not going to be able to learn. These are intertwined. I want to leave you with Greta Thunberg as a reminder of the power of young people, the power of young people as the next generation of leaders. They are arguably the current generation of leaders. We need to be equipping young people to be owning their place in the world, taking their place in the world, pushing us away so that their voices can be heard. And for those of you who are interested in hearing more, I would just welcome you. I'm president of the International Association for Adolescent Health. I was very disappointed not to be able to join those of you who are in Peru at our World Congress that was meant to be held last year, that is now going to be held. It's not a hybrid model. We've just made the decision to host this as a virtual meeting in November. So it will be in Spanish and in English, and I would love the opportunity to welcome any of you to the meeting. Thank you very much.
Thank you so much, Susan. Excellent presentation as usual. We have listened in this last block to a presentation from Dr. Charpak, focusing on the newborn. Dr. Garay from Chile presented on a child well-being program in Chile, and Dr. Sawyer spoke to adolescents, the health and well-being of adolescents from the life course perspective, all very illustrative of what was the concepts that were covered in the first block. We have gone a little bit over time, but I think it was well worth the time, and I think you agree with me because you stuck with us. And so without wanting to take more of your time, I just want to really thank the excellent presenters from the bottom of my heart for taking the time to be with us today. Today we spoke about a life course perspective and that the absence of disease is not enough. And I hope you were able to see through, illustrated through these presentations, what it is we mean, what are not only the concepts, but the implications and the importance of a life course perspective and a life course approach to broaden our perspective and to make our interventions more effective for now, for the future, as Susan said it in her presentation. And so we thank you for being with us today. And as we mentioned at the beginning, this is a series of webinars we are planning, all within the context of this document that was launched recently by the Department of Family, Life Course and Promotion on the importance of a life course approach. And so look for our next webinar in a few weeks. We hope you will join us then. And I wish everybody a very good rest of your day, or a good night for those who are further ahead in their day. Thank you all very much, and see you next time.